Hey nurses, today we're going to talk about IV titration in the ICU. Some of the resources are related to my workplace, but should still be relevant. All right, so here we use something called micromedics, which is inside of Cerner. So here, when you open the micromedics, you get some things at the top here that are important. One of them is IV compatibility, and that's where you would figure out what drips are compatible with which drips. Rule of thumb is your sedatives generally can be hooked into each other, and your vasopressors can be hooked into each other. Of course, this isn't a hard and fast rule, and nothing is always or never, but it's a pretty good rule to follow for the most part. We also have, it defaults to this keyword search for drugs, so you can type in whatever medication, it will give you info. And of course, I always recommend when you do like a compatibility chart that you print it out and have it at your fingertips. You can actually put in every antibiotic, every drug, everything that's going to go in the patient for that shift, all in one chart. And then you don't have to keep going back in there over and over. So there's the IV compatibility spot. There's a compatibility table example. This is what you would see if you typed in the drugs that are listed on the chart. You can see there's different symbols. I have the key there. So like a green check means it's compatible. Anything else, assume that it's incompatible because it means they haven't done enough research. Or they've done the research and it's going to crystallize the fluids in your tubing. Probably not going to hurt the patient because once it crystallizes, it's not actually going to keep transfusing. It won't go in the patient. There is a chance, of course, but the problem is you're going to have to get all new tubing. And if you were hanging something that was life-saving, you now are delaying the administration of that medication. You might have to get a new bag out of the machine. You might have to get new tubing, all of those things. So if it doesn't have a green check, put it on its own dedicated line. So you can see here that we have, for example, the way this chart works, we have dexmedetomidine on the left, and we can see over here on the right, we have fentanyl, and it says Y site with a green check. So that means that your fentanyl and your dexmedetomidine, which is Precedex, which is also a sedative, are compatible with each other. But then if you go over to the side here, we have the dexmedetomidine and ketamine are not compatible. And ketamine is not compatible with a lot of things. So, and then if you click in farther, so if you're on this chart and you click into where it says results, like 1 result, 10 results, it shows this little window at the bottom that I've got opened up, and it shows you which studies were done and what drugs were in the study and if they came out compatible or not. So this gives you kind of an informed decision. Okay, so that's the compatibility table. Okay, so we're going to talk about vasopressors first. So vasopressors can either constrict or dilate. If we constrict, we're going to raise the pressure. And if we dilate, we're going to lower the pressure. So first, we're going to go over those drugs that vasoconstrict or raise your blood pressure. You can see from the picture here, we have two different tubes. One is a regular blood vessel or tube. The other one is constricted, and you can see the arrows are pressing in, and it shows a much smaller lumen. So my best example for this is if you have a boba straw and a coffee straw. The boba straw is dilated, the coffee straw is constricted. So if you're trying to get the blood to flow through the boba straw, it will probably flow very easily, like that very thick milkshake that you are trying to drink. It'll go through it real nice. If you have the coffee straw and you're trying to put blood through that, especially if the blood is thick because it's full of sugar, like in DKA, or you're septic and it's full of all of those, icky byproducts of sepsis, it will be thicker. That yummy milkshake, you're going to suck all day long through that coffee straw and it's not going to come out. So The coffee straw is vasoconstricted and the boba straw is vasodilated. So that is reflective of in your blood pressure. A vasodilated blood pressure is a low blood pressure. It's very easy for that blood to flow. A vasoconstricted vessel, the coffee straw, is your high blood pressure. The pressure is very high because the blood is trying to force its way through that tube. Okay, so we're going to talk about those first. And this is kind of a high level overview of the drugs. We're not going to get into like the cellular level stuff. I'm trying to give you the need to know at the bedside. So norepinephrine, also called Levophed or Levo, because for some reason we have to shorten everything because we don't have time for all of these really long names, right? It's important for all of your drips that you're looking at your actual bag because you can look all over the place and find information. You can look at your pump. You can get information from report and your notes. You can get information from the computer and what the order says. But what really matters is what your bag physically says, because someone could have hung an 8 milligram and 250 ml concentrated bag, and your notes say 16 and 250, and the computer says 4 and 250. And what's actually affecting the patient is the 8 and 250 bag that's hanging up, going through the pump, going into their actual vein. So always start with what's hanging and compare it to everything else. If it's wrong, of course, we can adjust it, but know that whatever you adjust is whatever's hanging in going into the patient. Okay, so 8 and 250 is a standard concentration. Obviously, that's going to vary depending upon the institution. And you might want a higher concentration as your patient develops renal problems or fluid overload problems, okay? Levophed has changed over the years to being last line, last ditch effort vasopressor to now a first line vasopressor in septic shock and hypotension. All it does is vasoconstrict for our purposes. Central line is always best. If it extravasates or you have it go into the tissue, it can actually cause necrosis and you can lose a limb. So in a patient on Levophed, you should have a central line if you can. If not a central line, then a midline or an ultrasound guided IV, of course, is best. And you're going to want to keep an eye on that line whenever you're in the room. Just take a quick look. Make sure that it looks like the other arm. If it's going in an arm, make sure that you're looking at the site frequently, at least every hour or two, and teach the family and patient, you know, what to look for. This is what I'm looking for in this line. I'm making sure that it's not red, there's no drainage, it's not swelling, it's not changing color, those kinds of things, because the family is going to be hyper aware. And if they see something, they may see it first and they'll let you know. Okay. And then as anything that infiltrates, you want to stop it immediately, switch your drug to another line, and call the pharmacy stat. So you can see sometimes things have a reversal agent and sometimes they don't. But if it does, you're going to want to get that reversal agent in as quickly as possible. It's most often a drug that you would inject subcutaneously in multiple injections around the insertion site to try to mitigate any damage that that drug will do. Okay. You also, of course, want to document and notify your provider. So central line is best. It can cause a tachyarrhythmia. It's not super common. And you usually want to keep the mean arterial pressure greater than 65, but you want to look at your order and you want to talk with your provider because that patient, they may be okay with a MAP of 60, but you know, anything less than 60, you're not perfusing your vital organs. So make sure you're working with your provider on that. At this institution, we start at a rate of 4 mics per minute. Now, if your patient is taking and their systolic pressure is 50, you're probably going to turn that levo on at a higher rate. And then once you get them stabilized, then you'll stop and you'll see, okay, what rate did I end up on? And let me start titrating it back down to, you know, a better number. So here we start at 4 mics per minute, and then we're going to titrate 0.2 mics every 5 minutes. So you can titrate this one pretty quickly. And here we have a max of 47 mics per minute. And I know other institutions it's higher. In my personal experience, I've found that once you hit 45 or so, it's not going to make as much of a difference. Once you hit around 10 to 15 mics per minute on the Levofed, you want to start thinking about adding a second pressor. At our facility, we generally start with vasopressin. We add that after the Levofed gets to, we start increasing the levo. We also have epinephrine. Epinephrine is often used more towards the later drips. So by this point, we've usually got 2 or 3 drips going by the time we add the epi, unless you're talking about like an allergy or something. Or you've coded the patient, they cardiac arrested, and when you gave them the epi push, that was the last drug that brought them back. Then they probably need more epi or continuous epi, in which case they'll have a drip. Common concentration is 4 and 250. We can give this for bradycardia and hypotension. Notice it says and, not or. We're going to titrate to several things because epi is adrenaline and it will raise your heart rate. So we want to be cautious. We want to try to keep the heart rate less than 125, the MAP above 65. Again, work with your provider on that. And the systolic blood pressure greater than 90. And, it may vary a little. You may have a heart rate of 100. Your MAP is 66. Your systolic may still be 88 or 92. So these aren't like hard and fast rules. They're just kind of a guide. Okay. This can definitely cause tachyarrhythmias. It can also cause hyperglycemia. So you want to monitor that. And you can still give the push dose epi while they're on the drip. So let's say your patient is on an epi drip and they cardiac arrest, you can still ACLS dose them at 1 milligram. The picture of the box is the ACLS box that the epi generally comes in. Of course, it's going to depend on your facility. Notice it's 1 in 10,000. It's the high dose stuff. And here's a bag, an example bag of what epi looks like. It says high alert because it's a dangerous drug. Here we start at 1 mic per minute. We titrate 1 mic every 10 minutes to a maximum of 15. So I think one of the most important things is look at your patient's orders. It should say which drips to hang first and what criteria does the patient have to meet. What heart rate, what blood pressure, and then what am I hanging next if things go south? Just always have those, a plan in place so that you know what to do and what to titrate off first. Okay. Dopamine. Dopamine, we used to use very commonly. I want you to think about cardiac patients for dopamine, also called DOPA. Here's an example bag. This bag is 800 and 500. And I have a typo on my slide. I apologize. It should say 400 milligrams in 250 mLs. We always treat the low blood pressure with fluid first because what happens with dopamine is it's an inotrope and it makes your heart pump stronger. It's like the personal trainer for the heart, and it makes it pump stronger and a little bit faster as you get to higher doses. And so if you have no fluid in the tank to pump around, your heart is just kind of pumping dry. So you always want to give a little bit of a fluid bolus first. Obviously, there's lots of factors like, are they already in fluid overload? Do we have a CVP or a wedge pressure? Do we know that they already have enough volume? Does your facility have a Starling or a Cheetah that can tell us, hey, they have plenty of volume on board, let's start the dopamine, that kind of stuff, okay? This is used to treat bradycardia or hypotension, not both. So this is different from the epi in that it's or. So you may have a patient that comes in super bradycardic in the 30s. They're waiting for their pacemaker. We might hang dopamine as a drug to help keep that heart rate up. It also raises the blood pressure and vasoconstricts the higher the dose. So once you get to a certain dose, and it's going to be patient dependent, but let's say around 10 mics, that patient's going to start vasoconstricting and it will raise the blood pressure. Okay, so you just have to monitor that. Titrate to a heart rate less than 125, MAPA greater than 65. Central line, of course, is always preferred, can cause tachyarrhythmias at high doses. If your patient starts having PVCs or runs a VTAC, you want to back off. It's probably because of the high dose of dopamine. Here we start at a rate of 2 mics per kilo per minute. So this one is weight-based. We titrate 2 mics per kilo per minute every 10 minutes with a maximum of 20. Again, look at your orders and know what your parameters are. If you have no parameters, you need to talk to that provider and you need to get parameters because we want everybody taking care of the patient in the same way. And it helps with patient safety. Okay, so phenylephrine or neosynephrine or neo is more of a second or third line drug usually. And a standard dose, standard concentration is 100 milligrams in 250. There's a sample of what a bag might look like. Also says high alert on it. And this is used for iatrogenic hypotension. So hypotension caused by something that has happened to the patient, like a sedative or an overdose or over sedation. And maybe the patient is on propofol for sedation and it dropped their blood pressure, and we've given fluids and we've tried to do everything we can, but their pressure is still persistently low. We may need to hang some neo. This is generally a vasoconstrictor. It can cause a reflexive bradycardia, so you just have to monitor for that. We want to keep our MAP greater than 65, heart rate less than 125. Here we start at 0.5 mics per kilo per minute. We titrate by 0.4 mics per kilo per minute every 5 minutes. This is another one that you can titrate frequently. And here we have a max of 9.1 mics per kilo per minute. Remember that some places will do mics per minute, and so then all of these ranges will be different. So I also want you to note that these are very small doses. This is a very potent drug. So you want to be thinking in, point something when you're thinking about the doses. And then vasopressin or vaso. Here, a standard dose is 20 units in 100 mLs. This is to be used as an adjunct or in addition to other pressors. It's never used alone. Central line is preferred. There are different doses based on what's going on with the patient. Usually, at least here, we have a Levophed hanging, and it's usually greater than 10 mics. Then we start to add the vasopressin. For septic shock, you might see a fixed rate of 0.03 units per minute. And for GI shock, we would start at 0.03 units per minute, and then we would actually titrate by 0.01 units per minute every 30 minutes. So we're not titrating this one very frequently. And here we have a max of 0.1 units per minute. Again, super small doses and very important where your decimal point is and that we're titrating kind of slowly. Very potent drug. Dobutamine is kind of a funny drug because it can kind of cause multiple things and it's used for multiple reasons. It's a 1-to-1 concentration usually, so 250 milligrams in 250 mLs. And I also want you to think about cardiac for dobutamine. It's a cardiac kind of drug, usually used for cardiogenic shock or heart failure. It can cause angina, it can cause arrhythmias. PVCs and VTAC are very common. It can also cause hypotension because dobutamine makes the heart pump stronger, like it helps it along, again, like a personal trainer. But instead of vasoconstricting like dopamine does, it vasodilates. So people with heart failure used to go to Dobutrex clinics and to avoid hospital stays. So they would go home, and of course, they're thirsty because they have CHF. And they're drinking their water and whatever, and they're loading up on their fluid, and they would go into heart failure. And so instead of coming to the hospital, they would have a designated appointment every 2 to 4 weeks, and they would go sit in a chair in the clinic and get their Dobutrex or dobutamine infusion, and it would help their heart along, and it would help unload the fluid because we're vasodilating, we're getting the fluid through the kidneys, and we're dumping the fluid. So dobutamine is a good drug for someone who needs a little bit of heart help, but they also need to unload fluid. I don't see it used as often, but it definitely can cause PVCs and VTAC. I've seen that a lot. So make sure you're monitoring for that. As you're going up on your dobutamine, if you're starting to see more ectopy, you need to back off and talk to your provider and check your electrolytes. Okay. We're going to keep the blood pressure, the MAP, greater than 65, the CVP 8 to 12. So meaning we're keeping the patient hydrated, but we don't want them too dry, but we want to try to prevent them from being too wet. Okay, so something in more of the normal range. We also want to keep their heart rate less than 125. Central line is preferred. Here we start at 1 mic per kilo per minute. We titrate by 2.5 mics per kilo per minute about every 5 to 15 minutes with a maximum of 40. Okay, so those are all the vasoconstrictors, things that raise your blood pressure. There are less things that we use to lower the blood pressure because that's not usually the patient's problem. But we do get those people with hypertensive crisis, or maybe they have a neuro problem, or they're in some kind of hyperdynamic state. So then we have to use an antihypertensive. The goal is get the antihypertensive drip going, load them up with all the PO meds and maybe some transdermals, and then back off of the drip until it's off. That's generally what you're thinking. It's not like they're going to be on this drip for a long period of time. We just want to get the blood pressure down so that they don't have a stroke or something, and load them up with all those POs, whether they're home meds or we're adding things, or maybe they didn't know they had hypertension and now they're in a crisis, those kinds of things. Either way, that's what we want to do. So nicardipine is a pretty common drug now, or cardine, and a general concentration for this would be 40 in 200. I've also got a bag there of 20 in 200. It's used for subarachnoid hemorrhage, aortic dissection, where you don't want that blood pressure so high that it's going to burst something, either a weakened vessel or a dissected vessel where it's weak and the blood wants to go the path of least resistance. And then the patient, of course, could bleed out. It has a very long half-life, and it can cause a super low hypotension that takes a while to come back from. So you have to be very cautious with this drug. It can also cause a reflex tachycardia. We generally start it at 5 milligrams per hour, titrate 2.5 milligrams per hour every 15 minutes with a max of 15. So this drug, of course, ideally you would have an A-line, because then you would have a constant in real time blood pressure. It just depends on your provider whether they're willing to give you an A-line or not, but I would definitely ask for one. Nitroglycerin, also generally a cardiac drug. So it comes in a glass bottle. So you're going to have to open the vent on the tubing. So the IV tubing has the little drip chamber that you squeeze, and right above that, there's a little door that you can pop open. You don't want to stick needles and things in that. Yes, it makes it flow better, but now you've introduced something that could contaminate and cause infection. So you want to just open the vent if you have a glass bottle, any glass bottle. It comes 50 and 250, and we generally give it for chest pain. Someone comes in with angina, they come in with an MI, and we're titrating it to chest pain less than 4. 0 is unrealistic, but you want to talk to the patient about what their pain goal is. Generally, less than 4 is acceptable. We also want to keep their MAP less than 110 and hold if their systolic blood pressure is less than 90. This has a very short half-life. You can turn it off and it will quit working pretty quickly. It's contraindicated with a PDE inhibitor things that are used for if a patient has erectile dysfunction and has taken any of the drugs for that, they also lower blood pressure. They could be on it for hypertension that is very difficult to treat as well. But here's some examples: Cialis, Viagra, Levitra. If they've used any of those in the last 48 hours, then nitro is very dangerous for them. If they've had no response by the time you get to 200 mics, consider it ineffective, or maybe your IV's not working, those kinds of things. If they are on a fixed rate, there is a chance they could go to a telemetry cardiac monitored floor. So know what your policy is at your facility. We generally start at 5 mics per minute, titrate by 5 mics every 5 to 10 minutes with a maximum of 400. Once you get to like 100, 120, it's really not working. But the nice thing about nitro is it dilates the coronary arteries, and that's part of why it helps with chest pain. You hurt because you don't have oxygen to something in your heart. You open it up, your chest pain gets better. So know why you're on the drug. Are they on it for chest pain, or are they on it for their blood pressure? Generally, they're on it for the chest pain, but you need to know, what are you titrating to? Do I need to ask them periodically what their chest pain is, or do I need to be monitoring their blood pressure more frequently, or both? Esmolol is a beta blocker, or also called Breviblock. And we don't see it that much at our facility, but you might see it at yours. 2,500 milligrams in 250 mLs, also used for aortic dissection or coronary artery disease. It has a very fast onset, less than 1 minute, just like if you're pushing a beta blocker. Want to keep the MAP greater than 65, heart rate less than 125, MAP less than 110. Again, look at your orders and see what your parameters are. Central line is preferred. This drug is a little different. It has a loading dose. So you're going to give 500 mics over 1 minute. And then you're going to start it after that at 50 mics per kilo per minute, titrate by 100 mics per kilo per minute every 15 minutes for 48 hours max. And the max dose is 300. So again, any of these drugs that are continuous IV infusions for a high blood pressure, you want to get the blood pressure down, and you want to load them up with all the PO stuff, maybe transdermal, and then wean the drip off. Labetalol is very commonly pushed, but you can hang it as a drip. It can be a 200 milligrams in 200 mLs D5W or 100 and 100 NS, so usually a 1-to-1 ratio. I've got a 250 bag of dextrose here for an example, and 100 ml of saline. And then this is the little pink bottle. That's what it looks like when you draw it up and you push it. Generally, we push it like 20 milligrams IV push. So make sure that you're being very careful when you're calculating it and drawing it up. And you might, for safety, just double check it with another nurse. Not mandatory, but just good for safety. We start this at 0.5 milligrams per minute. We titrate by 1 milligram per minute every 10 minutes with a maximum of 8 milligrams per minute. Okay, so the next thing we're going to discuss are sedatives and analgesics. So the desired sedative effect, generally we're using a RASS scale, Richmond Agitation Sedation Scale. Not something that you necessarily have to memorize. In Cerner and probably in Epic, the RASS is built in. It's either a blue hyperlink or it opens as you click into your boxes. But this is what we want to titrate our sedatives to. And this is pretty standard in the ICU. So 0 is alert and calm, so that's fine as long as they're not pulling on stuff. -1 is drowsy. They wake up, but they're only awake for, 10 to 20 seconds, and they might go back to sleep. Light sedation, they wake up, they close their eyes. That's where we want them on a sedative, 0 to -2. Depending upon what's going on, if they have a neuro problem or some issue that you want them to be more sedated, maybe they have ARDS and they're fighting against the vent a little bit because their lungs are real stiff, they're having trouble breathing, there might be an order to keep them at -3, -4. They should not be at a -5, unless they're on a paralytic or something. So make sure that in your parameters on your order, it says what your RAS should be. If they're a +1 to a +4, that's a no-go. That means they need more sedation, or we need to get rid of whatever the medical treatment is that they're fighting against. Here's an example of what it looks like in Cerner when we document. It's under Body Systems Assessment 1, Neurological. Here you can see there's agitation, sedation, assessment. The little arrow next to the cell means that when you chart, other things will open. And then it's under the Richmond Agitation Sedation Scale. It's blue, meaning you can click on it. It will open up a resource and tell you what the RAS means. And then in purple, this is what you're charting. We often use dexmedetomidine for patients that are weaning from the vent because we have a nice sedative effect without the respiratory depression. We also often here use it for CWA patients or people that have overdosed or have some chemical issues, and it's going to take a couple days to get them kind of under control with whatever's going on with them. So 400 mics and 100 mLs is a standard concentration. We titrate to a RAS of -2 or whatever is ordered. Caution if the heart rate's less than 45. This will lower your heart rate. You have to be very careful if, let's say you're changing the bag or the drip or whatever, and your clamp is open and it kind of runs into the patient, you can put the patient in cardiac arrest. Be super careful with your Precedex. We take it for granted because it doesn't have that respiratory depression with it, so we feel like it's a safe drug. It's still a sedative, okay? We also call it Dex. I don't know if I mentioned that. It can cause a transient hypertension, so be wary of that. We give a loading dose for this drug as well, 1 mic per kilo over 10 minutes. Then we started at 0.4, titrate by 0.2 every 30 minutes with a maximum of 1.5 for about 24 hours. I have ish there because sometimes patients are on it longer, but generally we give this, say they're on propofol or fentanyl or something, and we wean off the propofol, we wean down the fentanyl, we start the Precedex, we wean them off the vent so they can still be on the Precedex when they're extubated. And then within the 24-hour period, we wean them off the Precedex, they're good to go. That's the general idea. All right, so propofol is an anesthetic. So anesthesiologists can push this. We cannot. Whatever you think about it, if we're giving a drip, what's the difference? I have a question. Yes.
You said that we turn off the sedation, like the probe or the other stuff they're on first and then start the Dex?
You can start the Dex as you're weaning the propofol off.
Okay,
Yeah, it doesn't have to be like I turn the propofol off, I turn the Precedex.
okay.
It can be I'm down to the lowest rate on the propofol. I've now added the Precedex, and then I'm going up on the Precedex as I'm coming off and discontinuing the propofol. It can be kind of a smooth, kind of overlap for a little while. Good question. Okay, so the propofol, it comes in a bottle usually. So again, you have to pop open that air vent so that it will not get like a suction to it. It comes 1,000 milligrams and 100 mLs. It also comes in these little itty bitty bottles. The smallest vial is what the anesthesiologist or RNFA would use to draw up the propofol. So you're probably not using that in the ICU as the RN. And then the little bottle, you have to be, hopefully that's not what's ordered because you're going to go through it really fast and you're going to be changing your IV bottle a lot. You really want the biggest bottle that's available, which is usually 100 mLs. Only intubated patients. This is the drug that Michael Jackson was on and he met his end. So you have to be super cautious. They must be they must have a protected airway. Titrate to the ordered RAS. Make sure you know what your RAS is, 0 to -2. Use a dedicated line. It is in a lipid suspension, so you have to be cautious of the liver and your triglycerides. Also, anything in a lipid suspension, which usually you know because it's white, causes increased risk of infection. So we change the IV tubing more frequently. Here at our facility, we change the IV tubing every 12 hours. So every couple of bottles, depending on your rate, you're going to have to change the tubing. So make sure that you're labeling everything so you know when to change it. Do not exceed 5 milligrams per kilo in head injury patients. RNs may not push boluses. Now, if you're in another state, another country, and that's allowed, that's fine. But know what your rules are so that you don't get into trouble. We should be interrupting the propofol every 12 hours or so for a spontaneous awakening trial and a spontaneous breathing trial if they pass the awakening trial, also called SATs and SBTs. Propofol is very nice because you turn it off within about 5 to 10 minutes. Its effects are gone. Patient will wake up. You can do a good neuro assessment. You can see, are they going to be weanable or not? If they are weanable, then no more propofol. Maybe now we need to add Precedex, or maybe they're good and they're just ready to be weaned. Or they're not ready to be weaned. They're pulling at everything. They're breathing really fast. Their vital signs are going crazy. Their blood pressure's up, heart rate's up. Turn that propofol back on. Usually sedatives we turn back on at about half the rate. It just depends on how out of control they become. You might have to turn it up a little bit, get them back sedated, and then back it back down. It kind of just depends on what's going on with the situation. We generally start this one here at 5 mics per kilo per minute, titrate by 5 every 10, and the maximum 75. We usually use 50, but our policy does say 75. You're going to be using a lot of propofol at those high doses. So you might consider adding something else or getting something as an IV push adjunct. Maybe they're in pain, and that's why the propofol's not working as well, because they need some pain coverage. Lots of things to think about. Also, remember to spot check the triglycerides every couple of days, depending upon your facility, what your policy is. But always bring that up to your provider. Hey, patient's been on propofol for 2 days. Should we do a spot check of their triglycerides? We may have to switch them to something else. Fentanyl, though it's not a sedative per se, it does work for sedation. It's nice because it also works for pain. So someone who's a post-op may only need fentanyl because pain is their big issue, and it sedates them enough to keep them comfortable on the ventilator. Here's an example of a fentanyl label, and it can be 2,500 mics in 250 mLs, used for pain and sedation. Titrate to the ordered RAS and CPOT, or whatever pain scale you use at your facility. CPOT we use for patients who are unable to tell us what their pain level is. It tells us things like what kind of activity are they doing, and based on what we chart, it tells us their pain level is about, a 4 or about 6, those kinds of things. Again, in Cerner, there's a hyperlink. There's information as you document. And we here are changing this to a weight-based. So now at our facility, this has changed. But it can be weight-based or it can be just mics per minute. So know what your policy is and what your ranges are. They are in very small doses. You have to think about how much fentanyl they're getting every hour based on how fast your drip is going, and make sure that they're not overdosing on the fentanyl. You want the lowest amount of fentanyl to keep their pain and sedation under control. Ketamine can also be used for sedation. It comes in a 500 and 250 bag. It can also be used, it's a sedative and analgesic. We need to talk to the doctor if the patient develops delirium, confusion, or hallucinations. Those are adverse effects of this drug. We also want to keep their heart rate and blood pressure in more of a tight range. So we want to keep it between 60 and 120 and the blood pressure between 90 and 180. We also want to titrate to the ordered RAS and a CPOT or pain scale equivalent to 3 or less. We start ketamine at 0.12 milligram per kilo per hour, titrate 0.06 milligram per kilogram per hour, with a maximum of 0.9 milligram per kilogram per hour. So again, notice these are much smaller doses than our other sedatives. Versed we used to use much more commonly, but ever since we started using propofol with its short half-life, we've not used Versed as often. This is a benzodiazepine, which also can lead to ICU delirium. So we need to be cautious with our benzodiazepines. It can be useful if you have a patient who is in status epilepticus or having frequent seizures, because it is a drug that we can give for seizures. It's a 1-to-1 concentration. It causes a sedative with an amnesia effect, which is very nice for procedural sedation because they won't remember what's happened. And then we titrate this to the ordered RAS, and we want to interrupt every 12 hours for a neuroassessment. But some patients take a couple of hours to wake up after they've been on Versed. So again, it's not as good for the neuroassessment piece, for the stopping and checking in with the patient. So just be aware of that. It may just take a while for them to wake up. And they're not going to remember what's going on. So you're going to have to frequently reorient them. So here we start with a 0.02 milligram per kilo per hour. And this is another one that at some places they're doing milligram per hour titration. So make sure you know what your policy is. We're going to titrate by 0.025 milligrams per kilogram per hour every 10 minutes. Max sedation is 0.16. Max status epilepticus is much higher at 2 milligrams. So make sure that you know what you're titrating to. Your RAS, seizure activity, or sedation. So here's an activity for you to do when you're looking at your bags. We've got several different bags and a lot of them look the same. So here we have a magnesium, 1 gram, and we have a midazolam, 100 and 100. They both are in foil packages. They both have orange labeling, but they're very, very different. You'd run them at much different rates. And you could kill someone if you ran the midazolam at the mag bolus rate. So make sure that you can spot the differences here. Here we have 2 bags of norepinephrine. One is 4 and 250, one is 16 and 250. So again, make sure you know what is infusing on your patient. So we did have a patient that they had fluid became a problem for them. So we quadruple concentrated their bag. So we changed it to a 16 and 250. For whatever reason, the scanning did not work properly. And so the computer did not know that it was a 16 and 250 bag hanging. And so when the nurse programmed the pump, it was for a 4 and 250 bag, even though it was a 16 and 250 bag hanging. Needless to say, they got a lot of norepinephrine that could have been very unsafe. Patient did fine. It was noticed by the nurse during report. Super important you guys go over your drips and look at your bags together during report so that you spot these things, because these bags look very similar. Where do you run the drips? I've got lots of examples of multiple drips. Here's what we call a scorpion. There's multiple ports that you can hang. Here is, oh my gosh, there's like 12, 16 pumps going, a couple of pressure bags. Here's some tips for your drips. Make sure your lines are free from tangles and knots. Make sure everything is clearly labeled, easily identifiable. If nothing else, your primary main line that you can push emergency meds through is labeled, preferably with a bright colored label, so that if you go in the room and you've got all those lines, you can point to the orange one and go, that's where you can push the drugs. That's the safest thing to do. Make sure that everything is properly dated. Your propofol has been changed within 12 hours. All of your extra ports, if you use Curo's caps, which I know is a brand name, the little caps with the chlorhexidine in them, if you use those, make sure that all of your ports are covered. And all pumps should be facing one direction and towards the door so that when you walk by or you glance in the room, you can see if anything is flashing or changing color so that you know there's something that needs to be addressed. Also, make sure that when you set your volumes, like with Cerner, when you scan everything, it automatically defaults to the full bag. So your pump will not alarm until your bag is completely empty. That's not helpful for time management. So once you scan and you start your pump and the computer is happy, change your volume so that it will go off when you have an hour or two left so that you can go get another bag and have it ready. Here's examples of where you can hang things. So here we have, it looks like maybe a PICC line on this arm, maybe a central line up in the neck. That could be a permacath. It's kind of hard to tell. Here's a very nice IJ central line. That would be a great place to hang things. And then this is a midline or an ultrasound guided IV. Make sure that you know how to identify the difference between those lines. If you're not sure, make sure you ask someone. And if you need to label it, label it. You know, label it central line or midline, PICC line, permacath. Nobody's going to fault you for putting the appropriate label on the appropriate site, as long as you're not violating any kind of infection control, rules. Okay, so here's a case study, and because, we're on the internet and I can't ask you for feedback, I'm just going to kind of run through it. So here's an example of an 85-year-old male with COPD and diabetes who came in with nausea, vomiting, diarrhea. We've got some labs here. We've got a low blood pressure, mean of 50. We've got a high heart rate, 140. It looks like the vessels are all vasodilated. The heart rate is trying to fill all of that space. So it's fast. We're breathing fast, respiratory rate of 26. We have a high temp. So it looks like this patient is probably dehydrated from the nausea, vomiting, diarrhea, and they could potentially be septic. Looking at our labs, you've got the normals here. We've got a previous result and a current result. The white cells are going up. The sodium is a little low. Potassium is going down. That will need to be addressed. BUN and creatinine, though coming down, are still high. So that's going to be an issue as far as, or it could be as far as giving fluids and antibiotics. The magnesium is low. That also needs to be addressed. Our lactic acid, though coming down, is still high. So we could have some sepsis here. Okay. So if you guys have any questions or concerns or anything that you want me to do a video on in the future, please put it in the comments. I also have my website linked, and you can always email me. So take care, be safe.